Assalamu alaikum. The long clinical consultation day. First scenario, Mr. Sami, 31 years old, complaining of lower back pain since 6 weeks. You will examine, take history and examine the patient and address his concern. Okay, ready? You can start, Dr. Iman and Dr. Mama.
Hello. Hello.
Hello.
أبتدي يلا. I will begin. Okay. Hello, I'm Dr. Ahmadi. I'm the doctor in the clinic today. Can I confirm that you are Mr. Sami and that you are 31 years old?
Yes, I am.
Hello, Mr. Sami. It's come to my knowledge that you are complaining of lower back pain since 6 weeks. So today we are going to discuss your symptoms and to decide the plan of management. I'm just going to take some notes to just be sure it's confidential. My full attention will be with you. Thank you.
Okay, doctor.
So can you tell me more about your complaint, Mr. Sami?
Doctor, I have been suffering from this back pain from 6 weeks it started. I feel it more in the morning. I can't move for about 15 minutes. Yes. Then when I start movement, I think it is reduced.
I'm sorry. I appreciate you. I appreciate your feeling. I just would like to ask: is it the first time this pain happened, or it happened before?
Yes, it's the first time.
So that it happened suddenly or gradually?
Gradually.
Is it increasing or is it decreasing?
The same.
Does it come in attack or it is continuous?
Not continuous. Like I feel it more in the beginning of the day.
Okay. So what increases pain?
I did not see anything increase it.
Rest.
Yes, maybe rest. You are right.
It is affected with movement and exercise.
But the voice is not clear.
I didn't get you. Hello, can you read your voice?
Can you ask again, doctor?
I'd like to ask: exercise improve or leave the pain or increase it?
The size improve them.
Relieve the pain, exercising relieve the pain, or after you come and work and do your daily job, it relieves pain, or when you are at test?
I can't hear well. The voice is cutting.
So, you hear me?
Yeah, Dr. Iman, check your connection, please. Your connection.
Okay.
Interrupted. Yeah, interrupted.
Okay. So now it's good?
No, still there.
Yes, okay.
Okay.
So,
Okay, carry on.
Yes, okay.
Okay, carry on.
So, does this pain increase with coughing or sneezing or straining?
No, doctor.
Okay. Does pain bending forward?
No.
Does it decrease when you take painkiller?
Yes. It's decreased somewhat.
Okay. Okay. I'd like to know exactly the severity of this pain if you are grading it from 0 to provided that 0 is the minimum pain and 10 is the maximum. So you will give it a score of what?
About 5 to 6.
I'm sorry for that. Do you want me to offer you some painkiller?
Yeah, now I am okay, doctor. No.
Okay. What is the nature of this pain? Is it stabbing pain? Is it some sort of dull aching pain? Can you just say the nature
dull
of
aching.
pain?
dull aching.
It's done aching. Okay. So is this pain associated with morning stiffness and rigidity?
Yes, doctor. Yes, I still about 15 minutes before I can move.
Yes, I'm sorry for that. Is there any association with stiffness in your neck also, and restricted movement in your neck and your back?
Yes, in my neck, but it's little more in my back.
Okay. Is it associated with is there any kind of have you ever experienced a lower limb weakness or altered sensation
No,
or any uncontrolled water work or bowel habits?
no, doctor.
Okay. So is there any cough,
Cough? No,
difficulty of breathing,
no,
any racing of your heartbeat,
no, doctor.
any chest pain?
No,
Did you ever come at night grasping for air?
no,
Is there any swelling in your lower limbs?
no,
Is there any phlegm in your have you once experienced phlegm in your cuff
no,
or difficulty in breathing?
no, doctor.
Any runny nose?
No.
Okay. Any change in your water work?
Change like what?
Fussy, like fussy water work?
No, doctor. My water work is as usual, no change.
You never experienced any burning sensation
No,
in your water? Any discharge from your private area? I'm sorry to ask you that.
no, no,
Okay. Any ankle pain?
no, doctor.
Any skin rash?
No,
Any pain in your knee joint or any joint in your body?
only my back, doctor. And sometimes my neck also.
Okay, I'm sorry for that. Is there any change in your bowel motion?
No, doctor.
Any tummy pain?
And what?
Any tummy pain?
No.
Okay.
Okay,
Any,
Mama. Okay,
any
Mama.
change in your mood?
I feel not changing mood, but this been irritating me.
Okay. Any trauma or damage back?
What? Oh,
Trauma or
Mama. Voice again, not clear.
Any trauma or deformity in your back?
No, no trauma, doctor. Deformity, I don't
Deformity,
know.
okay, in your
I
back?
don't know. I don't know. I can't see my back.
Okay. Can you tell me about your diet? Are you taking a well-balanced diet?
Yes, my diet is the same. I eat everything.
Do you take adequate dairy products and milk products?
What?
Do you take adequate products?
Adequate? I take everything,
Milk
but I
products
don't know if I take milk products. Yes.
and eggs?
Everything, doctor. I didn't do any restriction to anything.
What about your exposure to the sun? You are exposed adequately to the sun?
And yes, because I am driver and I go to the outside in the sun.
Okay. Do you take any drug like steroids?
No,
Okay. I'm just gonna ask you some question. Have you ever experienced some fever,
no, doctor.
any fatigue,
No,
loss of weight?
No, doctor.
Any pallor? Or somebody
No.
told you that you look paler than before?
No.
Any lumps or bumps in your body?
No.
Any history of traveling in the
Of what?
last few years? Traveling.
What?
Traveling.
Traveling?
Yes.
No.
Any history of contact with animals?
No, doctor.
Any history of contact with people who had cough and tuberculosis?
No, also.
So can I ask you some private questions?
Okay, doctor.
Are you sexually active?
Yes, I'm married.
Okay, I'm sorry to ask you. Had you many partners?
No.
Okay. Did you ever take illicit drugs?
Never.
Okay. So have you ever had some loss of consciousness?
No.
Headache?
Sometimes. Mild.
Mild headache? So
Yes.
is it, can you describe it?
Yeah, at the end of the day, sometimes feel headache and take paracetamol, and it is relief after it.
Okay. Is there any visual disturbance?
No.
Is there any muscle pain?
Any what?
Any muscle pain?
No, doctor.
Okay. So is there any family history of the same condition?
My father was having also back pain, but he didn't know any diagnosis.
And he didn't take any medication for this pain?
No, I take regular, the usual and painkillers only, but we didn't know, still didn't know what the cause was.
Okay. Is there any family history of any nasty grass or long-standing disease?
For me?
Or
No.
any long-standing disease? So do you have any past history of I should be aware of? Medical history like long-standing diabetes?
All the time I am okay, but only from these 3 weeks I start feeling the back pain.
Okay, I'm sorry for that. Can I ask you if you had any list of medication?
No, doctor, I didn't take any medication, only painkillers I need.
Can I ask you some social question? With whom are you living?
This is my wife.
She is supporting you at home?
Yes, of course. She is very supportive.
So if you need any social care, you can just tell me any time, so I can just refer you to the social care. So I would like to ask you, how does your condition affect your job?
Not too much here, doctor, because after this 15 minutes I can do anything.
2 minutes
Okay.
left.
2 minutes left. يا لهوي ما عملتش بتاعي. Okay. Are you smoking or taking alcohol?
No, doctor.
Are you driving?
Yes, I'm a driver.
I'm just advising you that you can inform the data, because maybe until you get diagnosed, it's better not to drive. Okay.
Okay, doctor.
So I just would like to examine your back. Can I
Okay.
see your back?
Okay.
I just would like you to stand and to put your head against the wall, the back of your head against the wall.
Okay.
تمام. Does the occiput is in contact with the wall?
Yes.
It is in contact with it. So I do the tremor test.
Tremor
Then
test?
that's what the modified. I will do the modified shimmer test, and I also the patient can do the lateral, and I will support him. I will examine the hand for any kind of for any nail change. And I see if it is a collapsing pulse, if there is bradycardia. Okay. I will examine the eye for any redness, for any jaundice. I will examine the hairline. I will also, if there is any kind of rash, I will also examine the mouth for any soreness. I will examine the neck for any rigidity or any subluxation. I will auscultate the heart, and for any I will auscultate the heart, and I will auscultate the chest. Is there any finding in heart test?
Yes, you will find a limitation in there's some limitation in trunk movement in all direction. Also, there's most of modified Chopard test, red eyes, otherwise normal.
Okay, I will examine the ankle for any pain in the back of the ankle.
Okay, no pain or tenderness.
So, Mr. Sami, what is your concern?
What I have, doctor? Why I have this pain?
A multi disease, which is ankylosing spondylitis. This disease it affects your spine, eyes, and your lung. Okay. And I'm going to refer you. I'm going to refer you. We're going to confirm this diagnosis with the blood test and the imaging, and I'm going to refer you to a multi-specialty, the lung doctor and the heart doctor, the physiotherapist, and we are also going. And then we are going to confirm the investigation.
Okay, doctor. Thank you.
Is it okay with you? Is there any other concern?
No.
Okay, let's start examining questions.
Okay, present your case, please.
I had a case of ankylosing spondylitis. She has a history of back, and she has presented also complicated with apical fibrosis.
Male patient, doctor. Male patient.
Yes, she has he has fibrosis in the chest, and he had
voice again not clear.
She has a positive modified tumor test, and by inspection, anyway, positive modified tumor test. Yes, and she had restricted the neck mobility.
Okay. What's your differential?
My differential, the first differential, it will be ankylosing spondylitis. The second differential, it will be the oldest negative, which is rheumatoid, which is the psoriasis. Is because the patient had no skin rash, and the one is empathic arthropathy because he has not blood. He has not in his bowel motion. And the first one, it would be because the patient has no problem in his water work, he has no dental discharge. Okay, and I had excluded the traumatic causes.
Okay, Mama.
Okay, I had excluded all the mechanical causes like osteoporosis, trauma. All of that.
How will you manage this patient?
Investigation apart of I will do CBC. Okay. And then I will do some genetics like at AB, and I will do rheumatic factor. Sorry, the rheumatoid factor. It will be negative. And then I will do HLA-B 27. To confirm the diagnosis, I'm gonna do X-ray on the spine and the sacroiliac. It will show some bamboo sign or sacroiliitis. I'm going to do MRI to confirm the diagnosis, and then I will do investigation for the complication, which is like chest X-ray, and I'm gonna do high resolution CT scan and echocardiography, because they may be ECG, because they may be AV block, certain degree of AV block, and I'm gonna do echocardiography to see if there is any aortic regurg, and then I guess it is the most important investigation and urine analysis, because sometimes there may be myelaidosis, so I will do the albumin creatinine ratio and the 24-hour urinary protein. And basic investigation, of course, like CBC, renal function test, liver function test, and inflammatory markers, all of them.
How will you treat the patient?
Number one, there'll be pharmacological treatment, and there'll be pharmacological. The non-pharmacological, it will be in the form of the patient counseling and the form of psychosocial support, occupational support, and the physiotherapy, the cornerstone of treatment. And then there is a pharmacological treatment. It is mainly a painkiller, which is non-steroidal anti-inflammatory drug. And we can do intraarticular injection of corticosteroids. And we can use DMARD. If it is extra outside the spine, I can use DMARD like sulfasalazine. But if it is spinal causes or axial causes, I can use the biological treatment, which is like adalimumab and etanercept and golimumab.
Okay. Okay, thank you.
I don't know.
You're done, Dr. Marwa, the question?
Questions?
Do you have other questions?
No.
Okay, I will ask her one question, Dr. Iman. What image you want to do to the back first?
Can you ask the question again?
What image you want to start with to the back? What image? Sorry?
And then X-ray. X-ray spine.
Yeah, X-ray. Yeah, X-ray, spine, and sacroiliac, not only spine.
And sacroiliac joint.
Yeah.
Sacroiliac joint.
But early stage of the
And
disease, you cannot see.
MRI.
Yeah, X-ray at least 6 months after starting the disease. But early stage, MRI is diagnostic.
MRI.
Okay?
Fine.
Yeah.
Yes.
Yeah. Okay. Dr. Marwa, you can comment now, please.
هو دي clear case of ankylosing spondylitis, but Dr. Iman in history should be more organized and avoid repetition of questions and avoid unrelated questions. I think you cover everything in differential diagnosis in questions, but sometimes you repeat the questions. Otherwise, you did well.
That's the question I would like Dr. Bassem. I would ask you. I'm just a bit confused, Dr. Bassem. If I know that because and I get the diagnosis of ankylosing spondylitis, I'm just supposed to I have to cover of back pain, even all the traumatic causes and the causes of osteoporosis and so on. I'm just a little bit confused. Am I supposed to?
Okay, before answering the question, Dr. Iman, please.
I'm confused.
Yeah, I will answer your question, but please check your connection or check your earbud. Or, we can hear you interruptly. There is something in your either the earbud
Yes
or the internet connection. Yeah. Please try
Yes,
to reconnect. I will answer your question.
yes, I connect.
Okay, you can hear us now? Okay.
Yes,
So
I can.
if you start my favorite approach, you will start analysis of the complaint. And you did it. The onset, the course duration, and is it the first time or previous attack? What increase, what decrease, and the pain scale in this scenario. All this related to the complaint. You will start with, okay? Don't forget to ask about relevant system. In this scenario, you ask about musculoskeletal, right? So any stiffness and what the meaning of pain in this scenario you have to ask. Is there stiffness or no? All this question and the relevant system just to confirm your diagnosis. I think in this scenario, you will know this is mechanical, inflammatory type of pain. Inflammatory type. Why? Because it will improve with movement and worse with the rest. And there is some stiffness in the early morning. So this is inflammatory type of pain. You have to rule out or to think about the possible cause of inflammatory back pain. In such age, in male patients, you will think about ankylosing, right? Or psoriatic,
Yes,
or reactive, or enteropathic. These are the causes of,
yes,
uh, what's called seronegative, inflammatory type of pain or inflammatory back pain. Ankylosing, psoriatic, reactive, and enteropathic, and inflammatory bowel disease as well. Okay, these are the possible cause in cases. You have to think about these during systemic review. How to roll out everyone, and I will tell you while taking or while doing the systematic review. We will do it from the systemic review without confusion, Dr. Iman. So don't ask special question for each type, or you can do a systemic review and you can pick up the cause while doing the systemic review. How? I will tell you now. So we'll start as my favorite approach after analysis of the relevant system. You have to roll out the alarming symptoms and as you did the question of alarming symptoms. Did you lose the control over your back, your bowel habits, or you have any weakness in the lower in the legs, not lower limbs? But this question you should roll it out with the mechanical causes more. This is not mechanical pain. This is inflammatory pain. However, if you want to ask, you can, but I think in the inflammatory type of pain, it will not affect the nerves. This is something in the joint, not in the nerve roots. So it will not compress over it. You can ask this question with the mechanical type of pain. Let's go to the second system you have to analyze, the constitutional symptoms, as I prefer. So the constitutional to roll out cancer or inflammatory, connective tissue disease or serious infection. As we know, the lumps or bumps or loss of weight, loss of appetite, and rise of body temperature or night sweats to rule out something serious or infection or cancer. Let's go to the next question or next system you have to ask about, which I believe it will help you to reach the diagnosis, the systemic review or the past, before that, the past medical history. Do you have any past medical history? If not, either he will tell or she will tell you, yes, I have. Analyze it. I have diabetes, I have the hypertension, I have any type of disease. He will tell you, and you can ask about this procedure. You can ask about surgery, allergy during taking past medical history. So it's past medical and surgical, and allergy and medication list, whatever. Now the systemic review and the role of every system to help you to reach the diagnosis. You will start from the head down to the toe. Don't ask about chest pain before asking about headache. I notice you ask CNS the last system, which is make you like unsystematic. You will ask the CNS after finishing the whole question of the body, means you are not going systematic. Okay, so we'll start from the CNS. Any headache, any weakness, or any sensation, different sensation, pins and needles, any vision problem, any redness in the eyes. Here we can pick up one system related to the ankylosing. If you notice there is redness of the eye, so you'll put in your mind what, Dr. Iman, as anterior uveitis.
Um,
And ankylosing. So ankylosing, it's related to the anterior uveitis related to ankylosing spondylitis. This question will give you a clue about spondylitis, ankylosing spondylitis. Let's move to the next system, or the thyroid or endocrine. I think thyroid here no role, unless there is co or association of a thyroid, which is not usually happen. Okay, next system, the cardiovascular. Here you have two questions for the chest pain, for example. Do you have any chest pain or awareness of heartbeat? What do you think the awareness of heartbeat here can give you a clue for what? He will tell you, yes, I have awareness of heartbeat. For example, so you will ask him, what type of awareness? Is it fast or is it slow? He will tell you it's slow. It guides you to what? AV block, for example. AV block also one of the association to the ankylosing, right? Chest pain, sometimes if he has anemia or anemia of chronic disease, but it's not conclusive for ankylosing. The next, short of breath and cough. In our case, you will have short of breath or cough, dry cough, and you can later on do examination, and the examination will guide you. There is apical crackles, inspiratory crackles, which is not improving with cough or not doesn't change with cough. So it will help you to diagnose as ankylosing associated with apical fibrosis. Now the GI, any difficult swallowing, any change or acid brush or any change or tummy pain, any change of your bowel habit. All this will guide you if there is inflammatory bowel disease association or it's the underlying cause. Inflammatory bowel disease, you will have diarrhea,
yeah.
of course. Yeah. If there is bloody diarrhea, the patient will have anemia. The anemia will lead to palpitation. You can have also chest pain due to anemia as a cause of or as a symptom or as a complication of inflammatory bowel disease passing blood, and patient will be present with anemia. Okay, so this is the second disease, inflammatory bowel disease, or as a second cause, inflammatory bowel disease. So we have two causes now of
Yeah.
seronegative, either ankylosing or inflammatory bowel disease. The next system, the genitourinary, any change of the water work. So if he has foamy or frothy urine, you can suspect ankylosing, complicated by amyloidosis. Or if you ask about any change and he told you, doctor, I have some burning. What do you think if he has burning?
I will think about reactive arthritis. Yes, reactive
Reactive,
arthritis.
perfect. Yeah, I have previous infection in my water work. Yes, I can suspect reactive. Either from this system or from any casual relationship. Yeah, I had casual relationship 1 month back or 2 months back, for example, and after that I noticed there is some discharge. Anyway, it will guide you to the reactive arthritis. Okay, you have now
Yeah.
three differential, and we got them
Yes.
from the systemic review.
Yes.
After that, the musculoskeletal. Any skin rash. Of course, we ask about joint pain previously during the analysis of the Raven system, and now we'll ask about the skin. Any skin rash. What do you think the skin rash will help you to diagnose?
It will diagnose a psoriatic arthropathy, and it is characterized that
Perfect.
it is usually in the hairline or behind behind
Perfect.
the
So
ear.
you can ask exact. Yeah. So you'll ask any skin rash. Yes, doctor, I have. Can you show me? He will show you either in the scalp, in the flexors, extensors, any area at the back, a scaly rash. You can ask analyze also this rash. So you have now the fourth or the fifth cause of a seronegative arthritis, which is psoriatic arthritis. From the systemic review, you can reach to the diagnosis. This is my take-home message from this case. You want to do it as differential. You want to ask every question related to every disease. It's up to you. But from the systemic review, you will pick up it, and you will look to the examiner that you are systematic in the questions. You are doing systemic review. By the way, every emergency case, you have to do the same systemic review. Any case come to you in the emergency, they are doing what's called systemic review. So it's not a matter of only take history. Okay. Now we will go to the social, any family history, any travel, and the social, or sorry, the sexual already you ask already, and you can ask also about HIV questions if you suspect something related to like reactive arthritis. And the next is smoking, alcohol, the job, driving. Here in this scenario, you have to ask about driving as you did. But try to ask the question quickly to do the examination because your time is up already before doing the examination.
Yes, doctor. Maybe the thing that confused me is that I had heard some tutor who said that you can ask about the differential diagnosis and then cover the rest of the systematic review. But actually, it was very confusing, and I will follow your method after that
So, okay.
that session.
If you do it, you can run the systemic review quickly without focusing. You might miss some systems because the time will be short to do all these things. So I believe you can do it from the systemic review. This is my favorite way, but if you have another approach, do it. The all aim
No,
in every station to reach the diagnosis, whatever the approach. So don't,
yes, okay.
yeah, just follow the approach you comfortable with. Okay.
Yes.
But I believe my approach is enough, adequate to reach with a systemic review. Okay.
Yeah,
Uh,
yes, I think
yeah.
this because the approach of differential diagnosis, for example, I cover some stuff in the GIT and then
Exactly.
I recover it in the GIT again. I recover the
Exactly.
TNS
Yeah.
in the end. I appear very disorganized. I'm never gonna do this approach
Exactly.
again.
Yeah.
It doesn't
You
work
will.
with me.
Exactly. It will show the examiner that you are disorganized. You ask question from system to as another system, jumping from here to there, because you are not focusing on one system. You are trying to pick up the case from questions maybe related to other system, but it's not in the systemic way. That's why please try to follow the systemic approach or systemic review approach. And from every question, you can add some question to one system that can help you to reach diagnosis rather than asking random questions. It will show the examiner that you are not organized. Okay. Let's move to the scientific point in this scenario. Ankylosing spondylitis. You have to do a lot of tests which you didn't do in this scenario. What are they? From even the standing, from the general look, as you did or as you said, any deformity, but don't ask the patient any deformity. How the patient will know if he has deformity? So you will expose his back by yourself. Please, can you expose your half of the body like this? This is the inspection step before examining anything. So can you ask the patient to take off his t-shirt. I want to see his back. Okay, this is by inspection. So this is what we call the general look. Of course, after rolling out any surrounding, any stick, any wheelchair. So please, can I see your back? So you can notice any kyphosis or scoliosis or loss of lordosis, right? Lumbar lordosis. This is by
Yes.
inspection before doing anything. Now the time for vitals. Can I know the vitals? Yes, as written in the paper. Whatever, you might have the pulse rate is less than 50 or less than 60 as AV block or any degree of the block, right? Now the time to examine the pulse. Why you examine the pulse in this scenario?
Because it may show every block.
AV block, not only AV block,
Or
aortic regurg.
bradycardia. Yes,
Aortic regurg. Yeah, bradycardia for
there's
AV
the
block.
collapse.
Aortic regurg.
Yes,
Yeah, so the pulse
I saw that.
nature, yes, the pulse nature. Yeah. Okay. Before moving forward, what in the hand you can examine apart
In
from
the
the
hand,
pulse?
I can see the nail to exclude psoriasis, so I can see exclude
Exactly.
any nail change.
Yes. Yeah. Yes. Any deformity, even not only nail only change, any nail change and deformity in the all joints in the hand. Why? Because there is always overlap between ankylosing and psoriatic. So you have to examine the hand from the nail up to the all joint in the hand. Okay. A pallor, yes, you can check the pallor. If there is pallor, it might be related to anemia due to anemia of chronic disease sometimes. Now you will go to the flexures. You have to check also for psoriatic, any rash, any psoriatic rash in the flexor or extensor in the elbow, I mean. Then you will go to the hairlines before examining the eye. The hairline, front and the back, okay, and behind the ears. Why? Also again for psoriatic rash. The eye for jaundice or pallor, and redness and for anterior uveitis. You can ask also about the vision for anterior uveitis. But if there is no redness, it's no need to examine for the field, okay? Because the anterior uveitis, if there is redness, it will show that there is some vision affection. But if there is no redness, no need to examine for the field. Then you ask the patient now to do the examination of ankylosing, if the case is ankylosing. How? There is two tests or three. You will ask the patient to stand up to the wall and to do the occiput wall test, right?
Yes.
More than 5 centimeters means positive. He will not touch the wall or there is more than 5 centimeters. Then you will ask the patient to do all movement for the neck, lateral and anterior and backward, right? And the modified Schober test, as well as also the touching the knee by bending forward or bending lateral. All this will show limited movement of the back or the neck. The modified Schober, as you know, by roller, making 5 centimeters above the dumbbell and sorry, below and 10 above. Ask the patient to bend forward if less than 21 extension increase in the distance. This is diagnostic or conclusive for ankylosing spondylitis. And you will ask the patient to sit down again to examine for the apical fibrosis. You can do examination to the apex, to the pulse, the I mean the pulse over the aorta, auscultate for aortic rigor, and amyloidosis. You can examine the knees, the kidneys, the knees for any knee joint osteoarthritic or any change in the knee joint, and finally the swelling in the legs. You can ask the patient to move if you have time. What do you think the movement of this patient, the gait, I mean, any change of the gait? They are saying, yeah, they are saying the same position of Parkinson, question mark, right? And he's moving as one. He cannot turn like flexible way. He's turning as whole.
Yes, yes.
Okay. Yeah, because
That
of
means
again
that
sacroiliitis. Yeah.
yes. Okay.
Okay. Don't forget also the sacroiliac at the area of back pain to examine. It's important because he came with a complaint of back pain. Okay.
Yes.
Yeah, I think this is related to the case from history taking and examination. The concern you already did, the driving, the job, the also the movement, anything related, you address already. Apart from that, including spondylitis, as you did, as you said, the best or the first option as a management, you didn't mention the hydrotherapy. It's very important, the swimming. You have to mention it
Yes.
in the non-pharmacological. You
I,
didn't say it.
I said
Yeah,
that.
this
It
you
is
said okay.
physiotherapy.
Yeah, okay.
No, no, I said physiotherapy. Is it enough? But not
Hydrotherapy.
physiotherapy.
By the way,
Yes,
hydrotherapy
as a
only
physio.
in the ankylosing, not only physio. Hydrotherapy only in ankylosing in the all
Yes.
bases. Hydrotherapy, okay? The pharmacological, as you said, two non-steroidal anti-inflammatory. If not responding, you will think about biological therapy, adalimumab or etanercept, but no TNF here, right? And yeah, treatment of the complication according to the complication. The investigation always, as I believe, general investigation, specific investigation, bedside, image, and invasive. Let's start by the general, as you said, CBC, chemistry, liver function, kidney function, coagulation profile, inflammatory markers. Specific here, HLA, B27, right? And closing, HLA, B27. And I think this is the only specific here. You can do a bedside test as ECG for aortic regurg and AV block, echo, as well as echo to confirm the finding in the echo as aortic regurg or any other valve affection. Bedside X-ray, yes, chest X-ray to confirm infiltrate, apical infiltrate for apical fibrosis. For imaging, you can add high resolution to CT chest to the chest X-ray, X-ray to the back, and MRI to the back to confirm the diagnosis. The finding in the chest X-ray, don't forget, sorry, finding in the X-ray of the lumbar, bamboo sign, you have to say. MRI for the sacroiliac joint, it shows also sacroiliitis. I think here, no invasive test, unless they think about joint aspiration, or for example colonoscopy if there is association or relation to inflammatory bowel disease or it is the cause or underlying cause of inflammatory bowel disease. So you can do in this step way manner in order not to miss any investigation. However, I think also I missed some investigation, but at least you cover a lot of investigation from general, specific, bedside, and imaging and invasive. In this way, you will never miss the most important investigation in each category. Okay. I think I'm done with the topic. Again, the comment, the organized way. You have to be more organized. Don't start with chest pain or short of breath without asking about headache, without asking about vision. You have to be look as organized in your approach. Okay. You have any question, Dr. Iman? Okay. Dr. Marwa, you want to add anything I miss? Anyone has any comment, any suggestion, anything missed by me he can add?
No,
السلام
but
عليكم.
inflammatory markers
عليكم
في
السلام.
الانفستيجيشن سوا.
Yeah, I mentioned inflammatory markers. Yeah, it's RCRB. Yes. Thank you, Dr. Marwa. Yes, someone said salam alaikum. Yes,
Yes,
there you go.
السلام عليكم. I am Dr. Yusuf.
Alaikum assalam.
I am a new
Yes,
participant
أهلا
with
دكتور
you
يوسف. Welcome.
in the group. I'm so
MashaAllah,
glad to
yes.
participate today. I have one comment and one question, if you don't mind,
Yes, Dr.
regarding
Yeah,
the
sure.
history taking. If we depend on the focused
Mhm.
history taking, depending on the differential diagnosis, sometimes we
Mhm.
might get, because some cases, even when we are taking the history, we don't know what is the differential diagnosis exactly. So it is better
Exactly. Yes.
to go systematically and to cover all the
Yeah.
systems and to get trained and to be
Exactly.
quick on covering all the systems so as not to forget. And at the end,
Exactly.
when we collect the points together, we might then think of the differential diagnosis.
Yes.
That's my comment, and my question is about Schubert test versus modified Schubert test. I believe that when we do
Yeah.
modified, we do 10 centimeters above and 5 centimeters
Yeah.
below, which
Below.
I find it sometimes a little bit sensitive. Could I do just Schubert 10 centimeters above? Has anybody tried this in exam? Is it acceptable to just do Schubert test? Because a little bit when you go down to dimple 5 centimeters, for the patient? Is it acceptable? Is it not embarrassing? Is it prefer to do Schober or modified Schober test? Thank you.
No.
Thank you so much.
Yeah. You're absolutely right regarding the differential diagnosis. Sometimes you don't know what the case is about, so how you can put differential without knowing the case. Yeah, I
Yes, you are
believe
scanning, and searching.
exactly. You are like scanning exactly. Yes.
Yes.
But previously, I believe you have to put some differential because he will ask you what's your differential. So you can suspect, for example, put differential diagnosis of inflammatory causes, and another differential for mechanical. Be ready to be going through either this way or that way, because if you have, for example, the case about mechanical, and you didn't put some causes of mechanical, the common cause particularly, you will be in trouble. As well as the same for mechanical. If you don't put three, at least common cause of inflammatory back pain in your differential, you will be in trouble while mentioning the differential to the examiner. So whenever you are going or starting the station, put differential for both. You don't know what the case about. So what's differential for mechanical, the common differential, for example, osteoporosis, as Dr. Iman said, osteoporosis, osteomalacia, or disc prolapse, trauma, you can put as a differential. Another differential for the inflammatory, put it in another category or another line, just to be ready if you have the case is inflammatory. So you will give him, the examiner, differential for mechanical if he asks it and the case was mechanical, or you will give differential for inflammatory if the case is inflammatory. This is regarding the first point. So you're absolutely right. The second point, which is the question, the Schober test. I believe the test or the Schober test is no more done nowadays. They are doing modified Schober. Even if it is embarrassing, I don't think, because the dumbbell is above, I think it's away from something to be embarrassing. At least offer it, ask the examiner, can I do the modified? Whatever will happen after that and he accept to do, so it will not harm the welfare, because this is a test and it's diagnostic test. You got it? But I think the Schober test itself is no more doing.
Yes. Thank you so much.
Most welcome. Thank you for your comment, Dr. Yusuf. Thank you.
Welcome.
Thank you.
So,
Okay, any other? Yeah, Dr. Iman, yes.
I can add to Dr. Yusuf that I had revised the Rider book, and he mentioned the modified Schober test.
Yeah, I think so. No more Schober test they are putting as
Yes.
an investigation.
But I see that Rider, when he mentioned touching the occiput with the back, he says that the patient had to put his he has to touch the wall with his occiput, and also with his the heel of his leg and his hip. The three should be in a normal
Touching
person.
the wall.
Yes.
Yeah, so you'll ask him to be touching the wall from 3 points. Yes, as you said. Okay, what else? Yes.
Doctor, you said that the TNF inhibitors had no role in. You said this. They had no role in ankylosing spondylitis.
What is it? Sorry.
The TNF inhibitors like adalimumab, etanercept, golimumab.
Adalimumab is not TNF, right? Adalimumab, TNF, I mean infliximab. TNF
I don't know
and
because
infliximab. No, adalimumab. I remember A for A, adalimumab, and etanercept for ankylosing. I remember
but you know,
A, but not TNF. I mean infliximab. I think no role in of infliximab in this.
because in the book of Roch, he said TNF inhibitors, and then he put two brackets, and he put inside the brackets adalimumab, etanercept, golimumab. So I understand that they are all types of TNF inhibitors, or I'm wrong.
What I remember TNF is infliximab. I'm not sure. Is it
Not
adalimumab?
Not only infliximab. Etanercept TNF inhibitors.
TNF. Okay, good. Thank you.
Yes.
Okay, so etanercept one of the TNF other than infliximab. Yes.
Yes, and there is a point. One of the teachers said that TNF inhibitors are used when there is spinal involvement, and DMARD can be used when there is extra spinal involvement, like joints and stuff like that. And the best one is sulfasalazine, especially in the inflammation of joint pain, and it is even written in the Roch book.
Okay, so you mean for the axial,
Yes,
right, and the peripheral joint?
yes,
Yeah, the Mars always for the peripheral joint, but for the axial, they are using the
TNF.
TNF. Yes. By the way,
Yeah.
methotrexate also for the peripheral joint.
Okay.
Yeah. Okay. Thank you, Dr. Iman. Any other question before moving to the next case? I hope the sound will be clear like this, Dr. Iman, in your practice in the second scenario. So can you give us the scenario?
Okay. I will write it now. Well, I'm sorry. I'm really sorry for the problems that have happened. In
No,
the
no,
system.
it's okay. It's okay. Any other question? Dr. Aisha, you want to add any comments? Anyone want to add comments? Dr. Isusa.
No, it is
Okay.
all comments. Thank you.
Okay, most welcome, Dr. Aisha. Dr. Isusa, you want to add any comments? Okay, Dr. Iman, if you're ready, you can post the scenario and we can start the second scenario. Anytime you have enclosing in the exam, you have to remember the 7 A's. 7 A's. Anterior uveitis, apical fibrosis, aortic regage, AV block, and the amyloidosis, and Achilles tendonitis. Any missing point? Anterior uveitis, apical fibrosis, aortic regage, AV block, amyloidosis, and Achilles tendonitis. I think there is. I missed 1A.
I think atlantoaxial.
No, atlantoaxial was
Subluxation?
rheumatoid. This is with the rheumatoid arthritis. Atlantoaxial subluxation with the rheumatoid arthritis. Good to remember it. You have to remember it with a rheumatoid arthritis. We always miss it in the rheumatoid arthritis. What's important to mention it, for example, if the patient going to be intubated or having anesthesia, general anesthesia for the movement of the neck. So you have to remember it. It might be as a question in the examiner time about the mobility of the neck in rheumatoid arthritis. So atlantoaxial subluxation is one of the most serious complications associated with rheumatoid arthritis. What is the last 7A? Anyone remember? Anyone can add it to the chat box?
I think you mentioned all, Dr. Bassem.
All of them? Okay.
It is 7, yes.
Okay, maybe I miscount. Anyway, we can start the second scenario. Dr. Iman, ready?
Dr. Iman sent it to me. He was sharing the.
To you?
Oh,
Or
I
to
will
the
share.
group? Okay.
Yes.
Yeah. Okay, Dr. Marwa will share it here. Okay, 26 years old female with recurrent abdominal pain. Let's assume she is Mrs. Julia Adam. Okay, Mrs. Julie Adam, 26 years old, with abdominal pain, recurrent abdominal pain.
Hello, good morning.
Good morning.
My name is Dr. Marwa, one of the doctors in the clinic today. Can I confirm you are Mrs. Julia and you are 26 years old?
Yes, I am.
Nice to meet you, Mrs. Julia. We are here today to discussing some issues related to your medical condition. Is that okay with you?
Yes, that's okay.
Okay. Can you tell me what you know about your health condition?
I had abdominal pain. It come and goes in the form of it's like attacks. And when attacks happen, I run to the water wash because of motion. I cannot, and this pain is very embarrassing, doctor.
Well, I'm sorry for that, Mrs. Julia. We are here to help you. Can you tell me when this pain started?
This pain started about 6 months ago.
It is continuous since 6 months?
No,
Continuous?
no, it's coming.
First time that this was no other attack before 6 months. First attack was before 6 months, right?
Yes.
Okay. What makes this attack come?
Can you ask
Did
me
you
again?
notice anything? Did you notice anything increase this pain?
Actually, it occurred after I eat. Yes, it occurred after I eat. So I prefer not to eat.
Any type of food increase the pain?
You know that I have noticed that after I go to the bakery, this pain is increasing, and so I'm not going giving bread from the bakery again.
Okay. Did you notice anything to make this pain better? If you prevent this baker, your pain improve?
It is better when I don't eat. So that's why I began to lose weight actually.
Okay. How much you lost? How many kg? Over how long?
I have lost about I have not weighed myself, but I can find it in my classes. They are getting wider.
Okay. This pain, can you tell me where is this pain exactly in your tummy? In which side? Hello?
The pain is diffused in my tummy.
Does it radiate to anywhere? Your back, your leg, anywhere? Or
No,
only in your tummy?
it's only on my
Okay.
tummy.
Can you give me number on a scale for this pain from 1 to 10, where 1
It's
the least and 10 the most pain?
it is about 4.
Okay. Do you have any change in bowel motion?
Yes, when this pain happened, I had loose motion.
How many times per day you have loose motion?
3 to 4, 4 to 5 times per day.
Do you notice any special character of the stool? Is it flushable or not? It's watery or
It is hard to be flushed.
hard to be flushed? Okay.
Yes.
Is it it is watery or containing any abnormal Have any abdominal appearance, or shape, or color?
I didn't notice, doctor. Although I noticed that it is hard to be, it is a little bit bulky. It is offensive, a little
Any
bit
offense?
pale.
Okay. Okay. Do you have any feeling sickness or throwing up?
Yes, sometimes I feel that I want to throw up.
Any difficulty in swallowing? Hello? Hello?
Yeah, I think from her side, Dr. Marwa, we are waiting for her.
Do? Yes, I'm with you.
Do you have any difficulty in swallowing?
No, I have no difficulty swallowing.
No. Okay. Do you have any increased body temperature?
No, it's right.
What?
No,
Hello?
there is no rise in body temperature. There is no body temperature.
Okay. Any lumps or bumps anywhere in your body?
No, there is lumps or bumps.
Any skin change?
No,
Any weather intolerance?
no,
Any skin, any joints pain or swelling?
no,
Any skin rash or any skin change? Any tightness of skin?
no, there's no scan.
No?
Dr. Iman, please check your connection. There's a problem in your internet connection. I already paused the time, Dr. Marwa, okay?
Okay, no.
You can disconnect and rejoin back, Dr. Iman, please.
I'm sorry, I'm very sorry.
Yeah.
So can you read the question if you
What was the last question?
Skin changes.
Skin change. Okay. Any skin change?
Yes,
Yes.
there
What?
were some I don't remember, but once there were some skin changes on my chin.
In your chin? Can you
Yeah.
show me or describe?
No, it happened. It happened when it happened at the beginning. I guess that it was 3 months ago, but now there is no.
Okay. Do you have any medical history or any long-lasting condition?
No, I have no medical history. No.
Do you take any medication for any reason?
No.
Do you have any allergy?
No, I have no allergy.
Did you do any surgery recently?
No.
Do you have any family history of concern or the same condition?
No, I have no family history of same condition.
Any change in your period? Is it
Any change in
regular
what?
or no? In your period?
My period is regular, doctor.
Any chance to be, are you pregnant or any chance to be pregnant? No?
I'm not planning pregnancy.
Hmm?
I'm pregnancy.
Any history of miscarriage? Any history of
Hello?
any history of miscarriage?
No, I have no history of miscarriage, doctor.
I will ask you some rapid questions now. Do you have any mood change? Mood to change?
No, I know, my abdominal pain the rest of time make me have sleep, and it makes
I'm
me
sorry for that.
anxious about work.
I'm sorry for that, Mr. Vijay. Okay. Do you have any headache?
No,
Any blurring of vision?
no,
Any abnormality in hearing?
no,
Any abnormal sensation anywhere in your body? Tingling, needle sensation, numbness. Any
No.
weakness? Any weakness?
no.
Any
But doctor, there is
mm.
some I can now get easily fatigued. I feel that I'm always fatigued, doctor.
You have since when?
Since the beginning of my symptoms and since the tummy pain that I had, I feel that I'm not like before. I'm not active like before. I feel always that I'm fatigued and I cannot do many efforts like I were.
Anybody told you that you are paler than before?
Yes, they all told me this.
Okay. Do you have any shortness of breath?
And no, doctor.
Any heart racing?
No,
Chest pain?
no,
Swelling in your feet?
no,
Any cough or coughing of blood?
no,
Any abnormal, any noisy breathing?
no,
Any change in your water work?
no, doctor.
Regarding frequency, amount, color?
Color of what, doctor?
Your water work?
No, there is no change of color of my water work.
Okay. I need to examine you. I will start
Okay.
by general look. Any
Okay.
the body and body mass index, and how much, and the vital signs. I will ask the all examination, and you will tell me the finding at the end.
Okay.
Okay. Then I will examine pulse for character, special characters and rate. I will examine the eye for pallor, jaundice, examine the mouth for any ulcers, and to examine, ask the patient to pinch the skin for any tightness. I
2 minutes
will
left.
auscultate the chest, and I will for any abnormal auscultate heart and chest, and then examine the abdomen for tenderness and any organomegaly. Then I will examine lower limb for any edema, and if there is time, I will examine for sensation and power in lower limb. Any finding? Any positive finding?
No, patient has
Hmm?
he has only pallor. She has pallor in her eyes.
Valor?
Pallor, yeah.
Valor only? Gait normal?
Just yes, everything is normal. She has only pallor. Only pallor.
Okay. What's your concern, Mrs. Julia?
I want why I had this why I had always abdominal pain and I always had to go to the toilets.
I highly appreciate your concern. After discussing with you and examining you, I believe that you have a condition affecting the absorption of nutrition in your gut. This result in these symptoms you have, and this fatigue and effort intolerance, and also this tummy pain and abnormal and loose motion. So we need to make further investigations, and we will update you by the result and the management plan.
Okay,
You have any other concern?
No, doctor, thank you.
Okay, time is up. What's the name of this condition? You didn't give here a name, which is very important.
Malabsorption or chronic pancreatitis. Malabsorption.
Do you think it's only malabsorption, or what kind of malabsorption she is? Anyway, let's go to the examiner question. Start, please, Dr. Iman. Dr. Iman, you can start the examiner questions. Hello?
Okay, yes, I'm with the examiner question. What is your diagnosis and what is differential diagnosis? Dr. Marwa, what is your diagnosis and what is differential diagnosis?
My diagnosis is malabsorption syndrome with vitamin deficiency, vitamin B deficiency with galoblastic anemia. The other differentials, chronic pancreatitis, and
your first differential is what?
maybe a pernicious anemia with malabsorption.
So, okay, and the second one?
Chronic pancreatitis. Yes, other differential celiac disease, but against this is symptoms or the character of the stool, and which is fit with more with malabsorption. Also irritable bowel, against this history of weight loss and malabsorption.
The other differential? So you said that pernicious, but why it was against? Why did you exclude that it is a celiac disease?
Well, no, not excluded. It is celiac. It is celiac disease.
So you say that it is celiac disease?
Yes, it's celiac disease.
Yes. And celiac can lead to plastic anemia. So it's
Yes,
not
yes.
against it.
Vitamin deficiency, yes. No.
And the patient said that she had problem with the bakery.
Yes, oh. Yes, all right.
Okay. So what is the rest of your differential diagnosis?
Now first is diagnosis is celiac. Other differentials, formal absorption and chronic pancreatitis and pernicious anemia may be associated with the celiac also. دكتور إيمان المايك مقفول.
Dr. Iman, we can't hear you if you are talking.
Yes, I'm listening to you, Dr. Marwa.
I answer your question. Any other question?
What will be the investigation that you are going to do?
I need to do baseline investigations, including CBC, kidney, liver and kidney function, vitamins, vitamin B12, vitamin D, and calcium level.
Yes.
Other invasive investigation may be upper endoscopy with biopsy, duodenal biopsy.
Are you going to do? So you said that you are going to do in the laboratory. The first one is what?
CBC.
Yes. What did you expect in CBC?
Anemia, which may be iron deficiency anemia or megaloblastic anemia.
Yes. Then if you are speaking about, what are the specific tests, laboratory tests for celiac disease?
Tissue transglutaminase enzyme and endomysial antibodies, IgA and IgM.
So what are the final diagnosis of celiac disease, or the confirmatory? How we will confirm it?
Confirmatory by biopsy with villus atrophy.
Okay. So will you do any other? So what will be of treatment? How you will treat the case?
First, non-pharmacological by gluten-free diet and counseling and education about the condition, and multidisciplinary team including GIT and dietitians to put a plan of diet, suitable diet to her, and inform her about alternatives for gluten-free diet. No usually no pharmacological, but in severe cases, steroid may be used.
If I ask you something, Dr. Marwa, if I ask you to tell me the differential diagnosis of recurrent abdominal pain, what will you say?
Of what?
Recurrent abdominal pain.
Current abdominal pain?
Yes.
الceliac, irritable bowel, intermittent porphyria, mesenteric, chronic mesenteric vascular occlusion.
So if I ask you how you had excluded them in the history? For example, if you say IBS, how you have excluded IBS in the history?
Excluded because by the character of stool and this weight loss. It's usually IBS not associated with weight loss.
Okay. And will you put the IBD in this differential diagnosis, or you had excluded it completely, doctor?
I excluded it from also the character of the stool with no blood stool.
Okay,
No
but
associated.
yeah. Okay. So if acute intermittent porphyria, how we will exclude it?
I asked the patient about her moods and any history of. I was I were about to ask her about any fits or seizures maybe associated with intermittent porphyria. Also, this family history, no family history in this patient.
Yes, that's why you had to cover the nervous system in those patients.
Mm.
What are you expecting in the nervous system in patients of acute intermittent porphyria, doctor?
May associated with seizures sometimes.
Yes, and neuropsychiatric
Seizures.
problem. So is there another features which can we exclude acute intermittent porphyria?
Features in urine color on standing.
Yes, that's okay. So complete your differential diagnosis of recurrent abdominal pain. You said mesenteric. You said mesenteric ischemia. Can you tell me how you will exclude or confirm mesenteric ischemia?
Mesenteric ischemia maybe with older patients than this patient. This patient is young with no other risk factors, no diabetes, no hyperlipidemia. So it's excluded from history.
Yes. And the acute the mesenteric ischemia will the patient also will fear eating because the pain will occur after eating, but after eating about
yes after 2 hours or
yes, after a few hours. Okay, so if I told you that complete your list of differential diagnosis of recurrent abdominal pain, complete it.
Hypercalcemia also. Hypercalcemia. I asked the patient about urine frequency.
Yes, and there is and in hypercalcemia there is constipation. There is
Constipation and abdominal pain also.
Yes, instead of okay. So complete your list, doctor. So if we are going to summarize, there is 3A of acute recurrent abdominal pain. The first A that you said is acute intermittent porphyria. The second A is the Addisonian crisis. Is it right? The Addisonian crisis, the patient come with acute, and it may be even associated with disease, and so it had to be excluded in the history because it may be associated with other autoimmune disorders. Isn't it right?
Also, the familial Mediterranean fever will be associated with recurrent abdominal.
Yes, we are going to continue. The second A, as you said, the acute intermittent, and we said the Addisonian. And the third A, it is the angioedema, hereditary angioedema. But the patient is characterized by being flushing in the face, and sometimes they had to remove the appendix in order for the patient to relieve, but the patient still had the pain because of the edema, of the continuous edema of the lining of the GIT. So that is the angioedema. That is the third A. If you are speaking about C, there is celiac disease, and there is also colics. It may be normal colic, like biliary colic, or it may even be a colic of the gallbladder. And then there is a D. You know what is a D? It is diabetes, diabetic ketoacidosis.
My differential was for chronic more chronic pain, not acute. Your differential now for acute, recurrent acute.
You know, it is this is a differential of recurrent. Of
recurrent and acute.
Maybe. Okay, maybe my question is over. Thank you. Thank you, Dr. Marwa. So we are going to hear the
Welcome.
feedback of Dr. Betty.
Yeah, yes, Dr. Iman is right. Recurrent means chronic. It's not only acute. So recurrence means coming and going or comes and goes in attacks. So these are the differential, as Dr. Iman mentioned them, from AIP, acute intermittent porphyria, and the second.
Yes, I told her the chronic. She told the acute.
No,
I
it's not acute. It's chronic because it comes and goes.
It's recurrent.
but
It is
acute
Yeah,
presentation.
recurrent. Recurrent.
Acute
yeah.
يعني
So
recurrent and acute في recurrent acute في
You know,
recurrent chronic
it is the approach of
يعني
one of
مثلا
tutor.
okay,
One of
what I
tutor.
know acute is acute onset means within 2 weeks, but it comes and goes means more than 2 weeks coming and going. So I cannot say that it's acute. You can say severe pain, but not acute because it comes and goes.
Doctor,
Yeah.
it
Okay.
is the approach. It is the approach of Dr. Abbas. He say if recurrent abdominal, he didn't say chronic or acute. He say recurrent. He say all
Yeah,
the
this
schools
is what I
recurrent
want to
cause.
say. Don't say recurrent
In
acute
attack.
because
Yes,
yeah.
he say it comes
Okay.
attack recurrent.
Yeah.
And
Yeah.
he say the acute. He says that the acute it is the acute pancreatitis or acute paracetamol. If it is pure acute and not recurrent, and he
Yeah.
says the chronic, the IBD, the IBS, and the mesenteric, and the malignancy, and the malabsorption, which is a celiac. So
Yeah.
he makes this approach to abdominal pain, and maybe today I'd like to cover most of the approach of abdominal pain with Dr. Marwa.
Okay. So as mentioned earlier, differential in basis of acute of recurrent abdominal pain, you have to think about these four questions or these four conditions, starting from acute intermittent porphyria and an hereditary angioedema and the familial Mediterranean fever and DKA and Addison. These are the most common, and you have to roll them out one by one or to think about them in the exam. Plus, you can think about the mesenteric ischemia chronic one, especially with the comorbidity patient like atherosclerosis, diabetic, hypertensive, or familial hyperlipidemia. So you have to suspect this, especially if the patient is complaining pain before eating. He will feel the pain while eating or before the meal, or sorry, but after the meal, not before, after the meal. So after he will eat, he will feel the pain. Okay, this is regarding the chronic mesenteric ischemia. Acute mesenteric ischemia never ever comes in the exam because it's like gangrene. It will be present with ischemia of the bowel, and it's very difficult to be presented in the basis. It's surgical point or surgical topic, not as a medical. But you have to know what the cause of the mesenteric ischemia. This is regarding the chronic mesenteric ischemia. Okay, you have to know what the cause. It could be atherosclerosis or it could be thromboembolic, like atrial fibrillation or showering or hypercoagulability state. It's not our topic today. Our topic about celiac. So it was clear, Dr. Marwa, as a celiac. Why? Why it's celiac? Because the patient told you clearly, I don't like to go to the bakery. I feel the pain while bring or buying some food from there, and the stool is difficult to be flushed. So don't think about malabsorption. You can specify the question for celiac at such age. Patient is 26, female. So you have to ask her what are the foods you feel like this diarrhea worse. She will tell you, as she said, bakery, so pizza, pasta. It's clear as an answer for celiac. So this is the clue for the celiac. What you have to do with the celiac, you ask about thyroid. Why? Because autoimmune comes together. So this patient might have other autoimmune manifestation, including the hypothyroidism or hyperthyroidism. And you ask also about skin rash, which is good question. What do you think, Dr. Marwa? Why you ask about skin change or skin rash? What do you suspect?
الدرماتيتس البيتيفورم اللي بتيجي مع السيلياك
Perfect. This is
especially
skin rash.
بالسن.
What other association? Dermatitis herpetiform and the skin change. What do you think?
Vitiligo also association.
Vitiligo. Yeah, vitiligo. Yes. So hypopigmentation as vitiligo. Or Addison association. Yeah, it might be there. You might have Addison along with the celiac. So you might have also hypopigmentation to the mucous membranes. So you have to think about other association. They will not bring celiac as a celiac alone. You will think about the complication or the association. What are the complication of celiac? You have to suspect to think about. Dr. Marwa.
malabsorption والأوستيوماليشيا
Perfect. All malabsorption or all supplements or vitamins deficiency. Vitamin B or vitamin B12, vitamin B6, the weakness, the tingling, numbness, or calcium. Yes, as you said, calcium for osteoporosis, osteomalacia, the iron, anemia. So you have to ask all these questions. She told you clearly that I have pallor, or they told me that I have pallor, right? Or I have look pale than before. And this explained the anemia. Then you can ask the question for anemia as you did. So whatever you have finding, you have to confirm it. I feel fatigue. Yes, the fatigue related to anemia. You ask good question. So anyone told you? Yes, I have been told that I have this pallor, or I look pale than before. You can confirm it by taking the systemic review. You ask about the short of breath, perfect, awareness of heartbeat. She will tell you yes, and you can confirm, is it fast? Yes, it is fast, and it will confirm the anemia. You ask about leg swelling, perfect. This is for anemic heart failure. But I prefer to do the question for systemic review in the same organized way from the headache, from the CNS. I think you did it later, but you did it. Apart from that, you missed the social, smoking, alcohol. I think it was related to the lagging in the internet. So I think the time was short because of the lag in the answers, as well as the examination. You did also the most important, the abdominal examination here. You have to offer examining the extremities for any vitiligo because she said there is skin change. I'm not sure what was it, but you have to ask about it or to examine it. The pallor, the pulse, the apex beat. I think you cover other examination, part of examination. If I will ask you, Dr. Marwa, a question. What antibodies you will start screening with?
انتوميزيال antibody
No. What immunoglobulin?
IgA
Yeah, and if the patient is having
if
deficiency, you will do
we do IgG
yes IgG because you mentioned IgM. So you will start by IgA, but if this patient is having immunodeficiency, IgA immunodeficiency, you will do IgG. Okay.
okay.
I think this is regarding the topic for the also celiac confirmatory test, the invasive test, endoscopy, upper endoscopy, looking for what you will do with endoscopy. Biopsy.
البيوبسي هو
Yeah, and you will see what? Villus atrophy and lymphocytic infiltration. There is any possibility to be complicated by cancer? There is?
الليمفو المالتا not with this lymphoma
Lymphoma, yeah. Yeah, there is possibility to have lymphoma. I think yeah, you have to ask about diet
lymphoma
history. Sorry?
lymphoma with H. pylori I think with celiac
Multi is with multi is a type of
Multi.
lymphoma and it is with H. pylori. But lymphoma in general, it is with the celiac disease.
Yeah,
okay.
yeah, it's enough.
And it is a red flag. And it is a red flag.
Yeah, it is a red flag. You have to give him red flag about loss of weight, significant loss of weight. Okay,
lymph node
one more.
enlargement and so on.
Sorry, Dr. Iman?
And lymph node enlargement and lumps
Yeah,
and bumps
yes.
and stuff like that.
Yeah, perfect, yes. As any cancer, yes. Okay, one more point I want to add for Dr. Marwa. The diet history is important. You have to ask here,
Yes.
yeah, any special type you feel it's sensitive or you feel the diarrhea worse. And you can ask her, she might be the vegetarian. So you have to ask if you suspect pernicious anemia, if you suspect related to the diet, vegetarian patient vitamin B12 deficiency. So you have to ask about her diet. Are you taking balanced diet or no? Okay.
Yes.
Otherwise, I think you did good case. Performance is good, but don't miss the social, whatever the time is there affecting. Ask about smoking alcohol, even while taking history. Does he smoke? Does he drink alcohol? What's his job? And if you suspect something related to driving, you can ask about driving. Otherwise, the other history parts, you did it well. You have any question, Dr. Mohammed? Yeah, Dr.
No.
Iman, yes.
Dr. Mohammed, I will just add some points. Dr. Mohammed Abbas add in the history taking of cases of celiac disease, because celiac come in differential diagnosis with many things. It come in differential diagnosis with the cases of acute abdominal pain and or recurrent abdominal pain, and also with loose motion. So he emphasized that in the history, we had to ask about history of travel, and in order to exclude gardiasis, for example, and chronic, which also lead to diarrhea and difficulty to flush gardiasis, okay? And also contact with patients who had TB because of the intestinal tuberculosis. And he also says that it's important to exclude HIV infection because also it leads also to some tummy pain, and it may lead even to enlargement of some lymph nodes, and even there is diarrhea. And he said it's very important that we do Amsterdam. It is very important to do what's called Amsterdam criteria to exclude cancer colon in families and stuff like this. So I just would like to add some points
Yeah,
that Dr. Mohammed
this
Abbas said.
in case you have a complaint of loose motion. Okay.
But Dr. Basin here, it is loose motion and abdominal recurrent abdominal pain. Yeah, the patient saying in history that there is loose motion and recurrent abdominal pain. So we are going to put all this in the differential diagnosis of loose motion.
I
Yeah,
excluded
no, I
infections
don't
after
think. No, the
after he
complaint here.
said after she said no fever. I excluded infections. I
And she
don't know
asked
it's
about
right
travel.
or wrong.
But the case here is abdominal pain, and you have to put differential for abdominal pain, not for the loose motion. Okay? Loose motion, one of the positive finding, but you cannot say inflammatory bowel disease here as a differential. Okay? Right?
Yes, that's what makes me
Or
confused.
cancer colon.
When I have more than one symptom, am I supposed to make for every one differential diagnosis, or
No. You will put
for the one
differential
in the complaint only?
for the complaint and the case. For example, in this scenario, the case is about celiac with abdominal pain. So what are the causes of recurrent abdominal pain?
Yes.
Right. The complaint here is recurrent abdominal pain for 6 weeks. So put what are the possible cause of abdominal pain in this scenario. Okay. So
Yes.
I will put acute intermittent porphyria, as you said, and it will be rolled out by color of urine and family history. You can say DKA, familial Mediterranean fever, and angioedema. You can ask also the question for angioedema, any swelling in the face, because these are the possible and the common differential diagnosis of a chronic or recurrent abdominal pain in cases.
Yes.
When they
But
ask or the presentation is diarrhea, you can say the cause of diarrhea and the loose motion as a common cases or common cause of diarrhea in cases, which are inflammatory bowel, irritable bowel, celiac, and you can suspect also malabsorption diarrhea. Okay.
yes, yes.
Okay. Thank you, Dr. Ema. Any else? Any comment else you want to add?
Thank you, Dr. Best. I'm sorry today. The coverage of the internet was not that good.
Yeah,
I'm
it's
sorry.
okay. It's okay. I hope all will get benefit from the record because there is some lag, but I hope all will. We can cover it by the topic at the end of the discussion or the discussion at the end. Thank you, Dr. Iman. Dr. Marwa, any question, any suggestion from you before moving to the discussion, open discussion? Anyone want to comment? Any missed point? We are here.
Dr. Bassam,
Okay.
I'm sorry, I had a
Yeah.
question. If I
Yeah.
had abdominal pain with loose motion, so
Yes.
the differential diagnosis, it will be celiac number 1, and IBD can also come with this, isn't it right? Crohn's
Yeah.
disease, it comes with abdominal pain with loose motion, and I can say IBS. Yeah, I can put them
Yes.
in abdominal. Yeah, isn't it right? Yes, I just would like to be sure.
Yeah, but as a complaint of loose motion, you mean, right?
Abdominal pain with loose motion. I ask both together.
Yes, yes. Okay, yeah. So it would be, as you said, because inflammatory bowel and irritable bowel, they present with abdominal pain along with the diarrhea.
Yes. Okay.
Okay. Any suggestion from others? Any missed point? Feel free to comment, to share ideas, to remind us what we miss. We are not here perfect, so there is missed points. If anyone discover, please share it with us. In order to be complementary, this meeting for all of you. Sometimes I miss, even the participant missing. So you can see from another angle which can be missed by us, but you can
هو
see it.
الالكحول in this case very important عشان
Yes,
due to
perfect.
chronic pancreatitis or malabsorption may be present by the same
Okay,
presentation.
this is one point. What other point related to alcohol in this scenario, particularly?
Uh,
If you will ask this patient, what you will ask her? If you ask her about alcohol and she told you, Doctor, I drink alcohol, what do you think? Anything important? What signifying this question in this scenario?
alcohol cause of chronic pancreatitis and malabsorption.
Okay, this is as a differential. No, if this patient is celiac patient and you confirm this is celiac,
Yes,
what
celiac
type?
alcohol beer type increase.
Perfect. Yeah. So you can even specify the beer as the question of alcohol. Why? Because other type of alcohol will not harm her. But whenever she will drink beer, she will have diarrhea. Why? Because beer one of the gluten including alcohol. Okay, I will ask you one more question. If this patient comes to you free of symptoms, and will you do the endoscopy, the investigation for her? She told you, I'm okay now. I want to investigate what I have.
If she stops, if she now on gluten-free diet, she should introduce gluten in her diet before
Perfect.
start
Yeah,
the investigations.
perfect. Yes. For how long?
For 6 weeks.
Within 6 weeks. Okay.
Yeah.
Plus, counseling is very important. Okay. Any other suggestion, Dr. Marwa, or question?
No.
Dr. Basham, when I the Dr. Marwa that I had rash in the past, I was trying to say that it was dermatitis herpeticum, but
Yes.
I for where it should be. So I say the chin. Is it in the face or in the chin? I
Elbow.
completely forget. Or anyone
It
in the
would be in
body.
the extensors and elbow.
Extensors.
Extensors of elbow.
Not only elbow, even knees,
More.
extensors. Commonly
So it can be in
in
the
the
chin
elbow.
of the legs. It can be in the chin of the legs.
Knees, the extensors and the knees, over the knees. The same as elbows.
Over the knee. Okay.
Yeah. The
Yes.
shin,
Okay. I
the
just
area of
forget the thing.
gangrenosum, bioderma gangrenosum of
Yes.
the shin, or erythema nodosum
So
over the shin. But
they
commonly,
disappear. They disappear. As I said, all they had to remain, Dr. Basim.
No, it might disappear. It's on and off. Okay, and what the treatment, Dr.
Okay, Dr.
Marwan? The
Bassem, thank
treatment
you.
of a choice. Thank you, Dr. Iman. Dr. Marwa, what the treatment of the choice?
Steroid
Steroid? No,
or protein-free diet also. Treatment of the
another medication.
medication.
Tacrolimus, local tacrolimus?
No, not tacrolimus. Dapsone.
So,
Yeah, Dapsone. Treatment of the choice. I think Dapsone in basis in two situation, but one of them, and you have to remember the dermatitis herpetiform. The other one may be some infectious disease, but I'm not sure about. Anyway, in this situation, you have to remember it's Dapsone for dermatitis herpetiform. Okay. Thank you, Dr.
Dapsone reduce the itching and the symptoms, but the treatment is strict also gluten-free diet.
Yes, of course. Yeah.
Yes,
Of
it
course.
is just for reducing the itching and the symptoms till the strict diet.
Yeah. So the cure for the all symptoms is gluten-free diet, but Dapsone for the rash itself, and it's very itchy, physical
I guess
and itchy. Yes.
I guess that Dapsone was also for leprosy.
Leprosy?
Yes, Dapsone.
Yes, it's originally it is
I
leprosy drug
search
at the
Okay,
at
perfect.
the in the
You can
past
remind
in
us.
the
Okay,
past.
what is it?
But we know it as a cause of in basis يعني it is not mentioned as this because leprosy is not anymore, but
Yeah.
it is as a cause of motor I think motor neuropathy. We have it in basis.
You mean it induced motor
Yes,
neuropathy? Yeah.
it
Okay.
induce motor neuropathy. Yeah.
Perfect. Yes. Thank you for reminding. So Dapsone is a treatment for dermatitis herpetiform, and it is the cause of motor neuropathy.
I search also for it. It is used for prophylaxis from pneumocystis جلفسياي HIV والسايد افكتس بتاعته ان هو كان كوز هيموليسيس في ال 6 جي 6 بي دي انيميا و also كان كوز ميس هيموجلوبينيميا.
Hemoglobin, yes. Okay. Another information. Thank you, Dr. Lawrence. So yeah, it might be used for BCB pneumonia in HIV, and it's induce or it can cause methemoglobinemia
Yes, and hemolysis في ال
and glucose 6 phosphate dehydrogenase deficiency can lead to anemia plus motor neuropathy, as Dr. Aisha mentioned. Yes. Thank you. So as I said, it's a meeting for sharing information. That's why anyone has any information want to share, please share it or remind us with missing point. This is the aim of our meeting. Any added information before ending the session?
Thank you for your
Okay,
time.
thank you. Thank you, Dr. Marwa, Dr. Iman, Dr. Aisha, everyone shared, Dr. Yusuf. As I promised, I will try to make another session in the week for the communication. So wait for the appointment, either Monday or Tuesday. I will send the time. And who's willing to practice, please send me a direct message through WhatsApp, my private WhatsApp. We will announce the session soon, either after 2 days or after 3 days, the same time. Okay. Thank you, everyone. Thank you for the attendance. See you, inshallah, with the communication session. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.